Hello everyone, welcome to this joint session. This is the first collaboration that we are doing, myself and Dr. Tala. We both have our educational YouTube channels which may be familiar with, and we will share the links. I am Dr. Sridhar Kalyansundaram and I work in UAE as a consultant neonatologist. And over to you, Dr. Tala.
Hi, good morning. It is morning here. I'm in Texas. I was extremely excited when Dr. Sridhar reached out that we should maybe start this collaboration, because we figured that there is so much in neonatology that can be learnt by just kind of discussing through scenarios rather than the actual kind of textbook type information that I've kind of been giving on our YouTube channel. So we're hoping that as we move forward, we're going to just start discussing different scenarios. And today we are going to discuss a delivery of a premature baby. So we kind of decided that we would just go over all the different steps and kind of the planning of what we are about to do if we are told that a 25-week infant, we randomly pick that number, is about to be delivered in your facility. So kind of the first thing that we were going to talk about is, what would we do? What sort of team would we assemble even before we got to the delivery room? And really what we have been discussing, Dr. Sridhar and I, is that there are people all over the world that are probably going to be watching this. And obviously, with the different levels of units, the different levels of the expectations of the survival in different countries, obviously, there's going to be different teams that are going to be going to these deliveries. I can't speak to all of that. I will speak to my own experience, which is in America. And at 25 weeks, we would definitely all be going to the delivery and expecting to resuscitate this baby. Interestingly, at 25 weeks, that's kind of the first gestational age in America that it would be considered that we have to resuscitate. So at 24, 23, 22 weeks, even if the parents came in and they were like, we just want to redirect to comfort care, we would have to accept that. So we would, even if it's a 24-weeker on paper, this hasn't happened to me for a very long time. If the mother said, okay, we just want to hold the baby afterwards, we don't want any active resuscitation, we would do that. At 25 weeks, even if the mother was saying, I want comfort care, at 25 weeks, we would resuscitate this baby, because really at that point, the survival and the developmental outcomes are considered so good that it would be unethical not to resuscitate. So 25 weeks, we're all going to this delivery. So our team would be a neonatologist or a nurse practitioner, sometimes both, depending on the hospital. It would be a transport nurse who is a highly trained nurse, who is excellent at procedures, very, very good at kind of just stabilizing babies. Then we would have a respiratory therapist who would be there to kind of set up the CPAP and the ventilator. And then we'd have at least 1 or 2 circulating nurses to kind of help with everything else. So really, we're talking about a 5-6 person team going to a 25-weeker. What about you?
It's almost the same, except that the manpower available may vary according to where you work, as you rightly said. And obviously, in our hospital, we would have the consultant. If during working hours, a consultant accompanies. Out of working hours, it may be 2 specialists who go. And this is a licensing system here that you have according to your qualification and experience. You have different levels. We don't have ANNPs as much in UAE, though some units do have, but the nurses who are trained in looking after such extreme premature babies. So it's important that right from the very start, we have the most experienced people managing these babies, right from the delivery room to the management in the NICU as well.
Yeah, absolutely.
So we have very little room for error in these babies. And
yes,
for those of you who don't manage these extreme premature babies, remember that we always go through a learning curve. And for your unit, it's possible that a 26 or 27 weeker would need the same diligence that a more experienced unit has for a 23 or 24 weeks. So pay attention to the same points that we're discussing, because the same would apply to whichever stage of maturation your unit is at the moment. In terms of skills, obviously, if it's multiple pregnancies, it becomes even more challenging with extreme prematurity and multiple pregnancy. We need really good planning, because to get those people, no regular unit would have that many experienced people readily available on the ground. You may have to bring people who normally would not be on call. So some units, like the bigger units, have a second on-call system where something unexpected happens, they have to come in. And we take the help of the anesthetist in some of the cases where you can't manage. But most of the big units have faced twins, triplets, quadruplets at extreme prematurities, and they are a nightmare to start with, but it's fun when you think about it later.
Yeah.
So
And then,
one important point I would add here is the preparation stage in terms of speaking to the family. All the points you mentioned, the ethics is a separate discussion, which I hope we'll be able to discuss another day as well. But all the risks associated with extreme premature, the hopes that we should be positive at the same time, we should not give too much hope because things can go either way. So staying positively cautious or optimistic and cautious at the same time is the way you could put it. So preparation in terms of risk factor profile and discussion with the obstetric team as to any other risk factors and encouraging them. Many of the obstetricians are hesitant to do delayed cord clamping for the extreme premature babies. And one important point I would like to mention about the delayed cord clamping is these babies, we don't expect them to be active or vigorous. So just feel for the cord pulsation as a baby delivers if you're the obstetrician, and don't hesitate to wait for the 30 seconds up to 1 minute. And Dr. Tala already mentioned the preparation stage. So the temperature in the labor room is key, and in the OR for these babies, ideally we should have 24 to 26 degrees. The warmer it is, the better. Of course, you have to fight with your obstetric team to get it, especially if it's the OR. But it's well worth it because the temperature makes a big difference. What would be the next point you would address, Dr. Tala?
Well, I just wanted to say that in America, we use Fahrenheit. So obviously the rest of the world is 23 to 25 degrees Celsius per the NRP. In America, that's 74 to 77 degrees. And just like Dr. Sridhar was saying, that is always a battle with the OBs because obviously they're all scrubbed up and it's so hot. But as I'm sure everybody knows, and if you've been watching our channels at all, you'll realize that probably one of the most important things that we can do for these babies is make sure that they don't get cold. So if babies get cold, all their outcomes are way worse. Morbidity as well as mortality is way worse. So keeping a baby warm in the delivery room, a premature baby warm, is probably one of the most important things that we can do. So the first setup for that obviously is going to be making sure that the room temperature is warm. And normally that involves somebody literally going to the temperature control in the room and increasing it. You know, that's one of the first things I check as soon as I get into the room. Then we obviously have to make sure that we have all the other equipment that we need to make sure that the baby is warm. And I don't know what sort of, setup everybody has in their rooms. We normally put the baby on kind of an isolette with the top removed so that we can move the baby directly into that same incubator in the unit. So that's how we would start. We would have the radiant warmer on. Then we would also have the trans warmers, those like great bags where if you squash them and squeeze them, then the heat comes on. And then for the tiny ones, we also have the plastic wraps and hats. So a lot of those initial stages are devoted to keeping this baby warm. And I'm guessing that you have some sort of similar setup
Exactly.
for that.
I mean, most of the quality improvement projects that neonatal units do might focus on the temperature care from the labor room, especially for the extreme premature babies. There are some recent studies which advocate caution when you're using a plastic bag under a warmer in addition to the transformers. So you have to be cautious. Probably if you switch off the system when you move, you can use the transformers during that stage as you move the baby out of the warmer when your electrical supply stops. And what you described, the giraffe, panda, any of these names we have for these sophisticated devices, which can quickly switch to the incubator once you are in the unit. So you don't need to move them. Most of these have a battery option as well. So in the more sophisticated settings, we have these advantages. Moving on from the temperature care, obviously, one of the key aspects is early oxygenation and whether you intubate the baby or you go for non-invasive. We are talking of a 25-weeker where we have enough evidence that we can use non-invasive. So can you describe what you do in your setup in terms of approach to labor room CPAP or NIPPV or whatever you use?
Yes, absolutely. So really, the support trials that we, were done 15 years ago, nearly at this point, I think 2010, late 2000s, this came out, where they showed that these preemie babies in the delivery room can be put on CPAP And as they move forward, they can really stay on CPAP. They don't necessarily need that early surfactant. And I think that was kind of like just a changing point in neonatology, where we understood that all these babies don't necessarily need to be intubated and given surfactant immediately, that they can be on CPAP. And then a lot of these babies now, what we're doing in the future, if they do need surfactant, then we're giving it in a less invasive way, which is a conversation for another day. So in those initial trials, they didn't include 23 weekers, and actually, I think the one in New Zealand didn't even include 24 weekers. But by the time we're in 25 weeks, for us, that is very firmly into, we expect to get out of the delivery room on CPAP. You know, for the 22, 23 weekers, in my head, those babies are going to get intubated as soon as they're delivered. The 24 weekers, you know, obviously we're going to try CPAP. We do have to have a low threshold. We're following NRP. If these babies do need intubation, or, you know, they are, obviously their heart rate is not going up, or they're still on 100% oxygen, then at some point we are going to intubate these babies and give surfactant. But for really a 24-weeker onwards, our goal is to get out of the unit on CPAP. Just like NRP, we start the FiO2 to 21 to 30%. So I kind of normally start at 30% for these tiny ones, and they'll come out. Hopefully the delayed core clamping has been done, like Dr. Sridhar was saying. We know that you know, it increases the iron stores, it decreases the chances of getting IVH, maybe decreases neck. So for us, that's a very important part of that golden hour that preemie babies go through. And as you all know, that first hour of their life can be absolutely critical in determining their outcomes. So, you know, this is all part of that beautiful golden hour. So, you know, they come out, delayed core clamping hopefully has been done. Like Dr. Sridhar said, they might not be crying through that. That's no reason not to be doing the cord clamping. Really, the delayed core clamping. Really, the delayed cord clamping, one of the few times that shouldn't be done is if we think that it's not actually helping. So there's something wrong, there's been an abruption, or there's severe placental issues where by doing it, we're not getting any of that blood into the baby. Otherwise, pretty much no matter how stressed the baby is, we want that delayed core clamping to be done. And we normally do 60 seconds. We bring the baby over to the warmer, and then really we're following NRP. So the first thing that we're doing is, well, in this situation, making sure that the baby's warm, covering up with plastic, and immediately applying that CPAP. So we apply the CPAP, kind of 30%.
Are you using the mask CPAP, or what do you use?
Initially, we would be using the mask CPAP. And then once we'd settled the baby in, we would transfer over to bubble CPAP is what we would use.
And that is with nasal prongs in the delivery room as well?
Yes. Yeah, exactly. We would, you know, after we'd stabilize the baby and made sure that the baby doesn't need anything else. What do you use in the delivery room?
Almost the same approach. I mean, and we can either go for NIPPV or
Yes.
CPAP mode, whichever you prefer. But one stressing point is that we shouldn't delay the surfactant if it is needed in these babies. So
Absolutely.
don't overuse pressure in the beginning, so you don't mask the need for surfactant. Because if you use higher pressures, naturally your oxygen requirement may be lower, but that may affect. So I wouldn't go to very high settings, maybe 6 or 7 CPAP and NIPPV of 20/5 if you have the option, or 20/6. One important point I would like to add is that cord milking, if you're unable to do delayed cord clamping, cord milking can be done in the babies over 28 weeks, but in the babies who are in the category we are discussing now, it's not recommended because there may be a higher risk of intraventricular hemorrhage. Dr. Anup Kataria's group had shown that, and I think the NRP, the American Academy, doesn't recommend that as well. So in terms of
Can I just say that?
Yeah.
Sorry, I just want to say that's a really good point, because OBs, I mean, this is a stressful situation for them. They have this tiny, tiny baby. I mean, they're not normally taking care of babies, right? So their gut instinct is to hand this baby over as quickly as possible. We've asked for delayed core clamping and they want something to do, right? So it's very tempting for them to milk, you know? So that is a conversation that you may actually have to have with your OBs, that we don't want the milking to be done in these preemie babies. Just stand there and allow the delayed core clamping to happen naturally. But yes, I think that's a very good point. And I interrupted you, I'm sorry.
No problem. I mean, we are looking for more evidence from the Torpedo 2 trial as well. And there is some evidence that in the extremely premature babies, you can go even to 30 to 40% to start with. So you're doing the right thing in starting with at least 30, but I mean, we can go anywhere from 30 to 40% if you're having the extreme premature babies. And obviously you can titrate quickly. The pulse oximeter, of course, goes in the plastic bag. If some of you are wondering why we use a plastic bag, in case you don't deal with such babies routinely, it's mainly to increase the reduce the insensible water loss by making it a high humidity environment immediately surrounding the baby. So this is a very important measure, and without this, actually, the babies lose heat by evaporation if they're under the warmer, and it's very difficult to maintain their temperature. So it's very effective, and we keep the plastic bag till you move the baby to a fully humidified incubator in the unit. Some of us keep it during the line insertion. We will come to that next as well. So we have now settled down the baby in the plastic bag. The pulse oximeter is on. Do you use ECG leads, or it's difficult for these babies?
No, we do. We do use those leads. And I think, as everybody who's ever taken care of a baby in the delivery room, when we're putting on a pulse ox, it can take ages for that to pick up. Normally, we're trying to do the preductal, so we normally do it on the right wrist. And as you all know, sometimes the perfusion isn't great, obviously, especially after they're born. They're moving around. We're all doing loads of things. So it can take some time for that to pick up. Obviously, the oxygenation doesn't really matter as much right at the beginning. We really need to make sure that the heart rate is good. So we do like to use those EKG leads to kind of look at the consistent heart rate. That is one of the first things that I will do when a baby comes out. Like, whether it's my role or not, if I'm in the delivery room and a baby's being born under any sort of stress, I want to make sure that that heart rate is above 100. So generally I'll listen, or I'll, with the tiny babies, you can literally just kind of, feel on their heart or on their umbilicus, or you listen with, a stethoscope. But obviously making sure that these babies have a good heart rate is going to be key in determining the next steps of resuscitation. So yeah, we do use the EKG. We put the pulse ox on as well. What about you all?
The EKG, that's one area we still need to improve, because some of us are hesitant to use it with, the nursing staff, the NICU nurses, hats off to them for their efficiency and skill level, because they keep improvising. Even for the pulse oximeter with the plastic bag, you need really to adapt yourself how the limb comes out. You make a small nick and take it out, put the pulse oximeter probe, put it back in. So, and the hat as well, put it quickly on so that the baby doesn't lose heat. So the EKG lead is one good learning point that we need to try and do it more. And there are situations where the pulse oximeter doesn't pick up, at least you have a reliable heart rate. So in terms of intubation, hopefully we don't need it, but if the baby does need resuscitation, we intubate. So if the baby does need intubation, do you give the surfactant in the labor room, or you still wait to go to the NICU?
No, we, and this has all been I've worked in different hospitals, and I feel like a lot of different protocols have slowly ended up giving the surfactant in the delivery room. I think that it makes that golden hour a lot quicker. Yes, it's very quick actually giving the surfactant, but if you're then getting to the unit and lines and whatever else, then I think it just adds a lot more time. So generally, if we are making the decision to give surfactant, we will give it in the delivery room. And
so the disadvantages here obviously are going to be that you're not confirming the tube position, and honestly, some units may prefer to move the baby unless your oxygen requirements or the ventilatory requirements are high and you need it as part of the resuscitation. But it's you could do it both ways, and if it's an experienced team, you know exactly where your tube is. We are going to use the end-tidal CO2, the colorimetry, to confirm the tube is in the place, and then you're going to give. So, it's not going to be a big difference. If you feel the baby needs it, give it where you need it.
Well, I will say that, and for a 25-weeker, really anybody less than about 28 weeks, so less than 1 kilo, we're generally using a 2.5 ET tube. For those tiny, tiny ones, we do have a 2.0 available, but those are 22 weekers or tiny 23 weekers. So generally at this sort of age, if we are intubating, we're using a 2.5 and probably a 0.00 blade. And I will say that, and I know there's a lot of conversation about how deep we should be putting the ET tubes in. And I think we found out for those tiny babies that if we're doing the weight +6, then if anything, it ends up going a little bit too deep. So, say at this point, if this baby is 800 grams and we are putting the ET tube in like 6.8, then that might be a little bit too deep for these tiny ones. Those numbers kind of work out as the babies get older. I will say, me personally, if I'm delivering a tiny baby in the delivery room and I am wanting to give surfactant, which obviously if you are intubating a preemie baby, you should be giving surfactant, right? I mean, if it's in, give it. So I will intubate, and, as you're kind of watching it go through, I will probably try to do it just past the vocal cord. So this isn't a baby that I'll necessarily use kind of the weight, or if it is supposed to be 6.8, I'll pull it back a tiny bit. Yes. I think the worst thing would be that if you are intubating and giving surfactant in the delivery room without an x-ray, obviously your biggest concern is that it's gone into the right main stem, that you've pushed it too far, which, as you all know, we all get a bit excited when it's very easy to just be like, I want to make sure it's in, I want to make sure it's in. You definitely don't want that in too far, because if it's in the right main stem, all the surfactant will go into that right lobe, and that really could be an absolute disaster. And so I agree with what you're saying. It's nice to have x-ray confirmation. And we've kind of started this whole thing where we actually are getting x-ray confirmation in the delivery room and kind of doing lines down there, but that's a talk for another day. So I won't put it in very far at all before we do give the surfactant.
Just another of us start taking the surfactant to the labor room. I mean, we keep it in the NICU, and that makes it, because you're allowed to put it back in the fridge just once, and you don't want to waste an expensive medication.
Absolutely,
so the medication is clear cut, and even if you're intubating, as per the bundles that most of us have, if the baby is stable enough, don't delay shifting to the unit and starting the rest of the care, because the blood glucose, the IV access, the fluids, humidity, everything has to start. So we intend in a stable, extreme premature baby to reach the unit by 15 minutes or 20 minutes max. If the baby needs resuscitation, of course, it will take longer, but the idea of keeping the baby in the labor room for a very long time has to change. So I think we were planning for 20-25 minutes of the session to start with. And of course, it's very nice to have this kind of discussions. Now we are about 5 minutes away from closing. So I would like to sum up what we have discussed and maybe add 1 or 2 points from your side. And then we will continue what we do in the next session as well. So in terms of approach to the extreme premature babies, we discussed that you need to decide in your unit which team is going to, but always allot the most experienced people right from the beginning for these babies. Preparedness is key. Think through the processes. Quality improvement is key as well. Anything goes wrong, you go back and look at it, see how you can improve it. And in terms of cord clamping versus milking, we discussed that part. I would reinforce that. We discussed the temperature in the labor room and your dialogue with the obstetric colleagues as well to get their support. Obviously, they are going to support you, and we have documentation, we have articles to support that as well. So we have to have as part of the perinatal meetings. And we discussed the approach to the plastic bag, pulse oximeter, hat, and the non-invasive approach to ventilation, even in the 25 weekers onwards. So what would you like to say as your closing remarks, Dr. Tala?
Well, just to your point that you were saying that, time is critical, that, I mentioned the golden hour. We're really trying to get these babies completely stabilized. Like, our goal is to get these babies stable on the vent with their lines in, with their fluids running, antibiotics if necessary, if it was a, choreo or whatever, by 60 minutes of life with the lid closed. And, different hospitals I've worked in have used different approaches. So for you, your approach is to get out of the delivery room as quickly as possible. We figured out most recently that everything works a lot better. We've got a large area just outside the delivery room where we can literally stabilize these kids. So we are getting these babies to the unit with the lines in, intubated or stable on whatever vent support that they need. And, with the lid closed, ready to go in the unit, really by 60 minutes of life. And that's kind of our key thing. The other thing that I want to say is the
facility for that. Obviously, it's great because you will not be distracted by anything else happening in the unit. And you are clearly not at pressure for space. So that's a big deal, and you have set it up in that. So that's a very good measure as well. Yeah.
This is an amazing nursing team that has kind of been running this, and they've been like superb. The other thing that I want to say is, like, going back to the golden hour is, the whole thing of CPAP is, our goal is with these babies is to try to stimulate them in a negative way as little as possible. So we're using the minimum amount of support, which hopefully is CPAP. Or once we put them, if they are intubated, once we put them on the ventilator, we want to use the minimal amount of support that we can do. We should be as gentle as we can with them. There's a lot of talk about the head position if babies are intubated. These aren't babies that we want to be rough with at all. So, a big part of these tiny preemie babies is trying to be as gentle as possible in that transition as they're slowly getting to the NICU. And that first hour is pretty intense, with the EKG leads and the lines and the CPAP or whatever else. And so as we're touching them and being with them, everybody really does need to stay calm and gentle with the babies as well.
Perfect.
Just adding to that golden hour.
You summed it up very beautifully, and I agree fully with you that what we are doing for the extreme premature or any baby in neonatology is supporting their physiology to adapt. We are not treating them, we are supporting them and transitioning their physiology. Even if it is a severe PPHN, it's the same. You understand what they are going through, you support them, and you give just what you need to support them. You never overtreat the babies, never overdo your blood tests or anything like that. So I would like to close this session with a passing remark that we will be sharing this in both our channels, and we will have the link to each other's channels, and both of us have put in a lot of effort, and obviously we hope that this kind of information will help you. Do comment to share your thoughts and any future topics you would like. Of course, we will continue this extreme preterm discussion for the next couple of sessions, and then maybe IVH prevention bundle can be a separate session as well. So we will look at options, but do comment, and your participation is key. And thank you for accepting to collaborate as well, and it's a very good opportunity to discuss more. So with this, we will both sign off from you guys, and hope you enjoy. Do comment. Dr. Tala, you're passing final comments.
Thank you. I just really enjoyed that. I really enjoyed chatting with you. I hope I didn't go off to too many tangents. I'm really bad at that.
No, absolutely. You speak very nicely, and it's passionate. Your passion shows. So thank you.